A new Ebola outbreak in the Democratic Republic of the Congo is raising fears of a wider regional health emergency after at least 65 people died, and hundreds of suspected cases emerged in a province bordering Uganda and South Sudan. The outbreak is unfolding in Ituri Province, one of the most unstable and difficult regions in Central Africa, where armed conflict, mining activity, weak infrastructure, and constant population movement complicate every stage of disease control. What makes this outbreak especially concerning is not only the number of suspected infections, but the strain involved. Early laboratory analysis indicates that this is the Bundibugyo strain of Ebola, a rare variant for which there is currently no licensed vaccine. Health authorities in the Democratic Republic of the Congo reported 246 suspected cases linked to the outbreak, while the Africa Centers for Disease Control and Prevention confirmed that laboratory testing had already detected the virus in most of the samples examined. Uganda's health ministry also confirmed that a 59-year-old man died in a hospital in Kampala after traveling from the DRC, signaling that cross-border transmission has already occurred. Regional officials are now trying to prevent the outbreak from expanding across one of the most porous and heavily traveled border zones in Africa. Ebola is one of the deadliest viral diseases known to modern medicine. It spreads through direct contact with infected bodily fluids, including blood, vomit, saliva, and other secretions, as well as contact with contaminated surfaces or dead bodies during burial preparations. Symptoms initially resemble many common tropical illnesses, including fever, weakness, headaches, and muscle pain, before progressing in severe cases into internal bleeding, organ failure, and shock. Fatality rates vary depending on the strain and speed of medical response, but some outbreaks have killed more than half of those infected. The Democratic Republic of the Congo has experienced repeated Ebola outbreaks since the virus was first identified near the Ebola River in 1976. This latest outbreak is the country's 16th recorded Ebola event. In most previous cases, the outbreaks involved the Zaire strain of Ebola, which became more manageable after the development of vaccines and treatment protocols over the last decade. The Bundibugyo strain presents a more difficult challenge because there is no fully licensed vaccine available for large-scale deployment. The geography of this outbreak adds another layer of complexity. Ituri Province sits in northeastern Congo, near the borders with Uganda and South Sudan. The region contains mining towns, trading routes, refugee movements, and armed militia activity. People move constantly between rural settlements and urban centers, often across poorly monitored borders. Health officials from Africa CDC warned that this level of mobility creates ideal conditions for disease spread, because infected individuals can travel long distances before symptoms become severe. Cases have mainly been reported in the Mongwalu and Wampara health zones, with additional suspected infections appearing near Bunia, the provincial capital. Mongwalu itself is strategically important because of its gold mining industry, which attracts workers, traders, transport operators, and informal labor networks from across the region. In areas like this, infectious disease containment becomes far more difficult because economic survival often depends on mobility. Even during outbreaks, people continue traveling between mining sites, markets, and border crossings. Regional health authorities are now coordinating emergency meetings involving officials from Congo, Uganda, South Sudan, the World Health Organization, and pharmaceutical companies. Their immediate priorities include isolating infected patients, tracing contacts, improving laboratory testing, and limiting cross-border transmission. The challenge is that Eastern Congo's healthcare infrastructure has been weakened for decades by conflict, underfunding, and political instability. This is not the first time Ebola has crossed borders in Central Africa. During previous outbreaks, infected travelers carried the virus into neighboring countries, forcing rapid international responses. Uganda has faced several Ebola outbreaks itself over the last 2 decades, including a major outbreak of the Sudan strain in 2022. The country developed stronger surveillance systems after earlier experiences, but officials remain concerned because Kampala is a major transport hub connected to East Africa's wider trade and travel networks. The world still remembers the scale of the 2014 to 2016 West African Ebola epidemic, which became the deadliest Ebola outbreak ever recorded. That outbreak spread across Guinea, Liberia, and Sierra Leone, eventually causing around 28,000 infections and more than 11,000 deaths. It overwhelmed fragile healthcare systems, disrupted economies, triggered international panic, and exposed major weaknesses in global outbreak response mechanisms. Since then, African and international health agencies have improved surveillance, laboratory capacity, and emergency coordination, but outbreaks continue to test those systems repeatedly. Scientists believe Ebola outbreaks usually begin after viruses circulating in wild animal populations cross into humans. Bats are considered the most likely natural reservoir, although primates may also play a role. Dr. Michael Head, a global health researcher at the University of Southampton, noted that several structural factors repeatedly increase outbreak risks inside Congo, including close human contact with wildlife, movement between forests and cities, dense rainforest coverage, and the region's tropical climate. Another major concern is public trust. Ebola outbreaks are often accompanied by misinformation, fear, and resistance to health measures. In previous outbreaks in eastern Congo, treatment centers and health workers were attacked by armed groups or distrusted by local communities. Some residents avoided hospitals because they feared isolation or believed health authorities were spreading the disease. Building trust is therefore as important as deploying medicine or equipment. What happens next depends on how quickly health authorities can contain transmission chains before the outbreak spreads into larger urban areas. One possible scenario is that aggressive contact tracing, border screening, and regional coordination succeed in isolating the outbreak within affected zones. Uganda's previous Ebola experience and improved surveillance systems may help limit wider spread if infections are detected early. A second scenario is more dangerous. If transmission accelerates across border regions or reaches densely populated cities with weak healthcare systems, the outbreak could evolve into a much larger regional emergency. The absence of a licensed vaccine for the Bundibugyo strain increases that risk, because authorities cannot rely on the same rapid vaccination strategies used during some earlier Ebola outbreaks. The outbreak also highlights a broader global reality. Infectious diseases emerging in fragile regions are no longer isolated local events. Conflict zones, migration routes, mining economies, climate pressures, and weak healthcare systems all interact in ways that allow outbreaks to spread faster and farther than before.